And there's your lungs. You've only got two. And that is an electron microscope photograph of those tiny little, if you go down all the tubes and you get right to the end, you get these little sacs, and there's a membrane there at the bottom of every one of those sacs. And I'm no biologist, but basically that's where the oxygen gets from the air into the bloodstream. And it passes through that membrane. That membrane is 1 micron thick. 1 micron. David says, if you had a piece of industrial kit that was critical to your processes with a 1 micron thick membrane in it, you would jolly well pay a maintenance contract to make sure that didn't break and that was in good condition. Why is it any different with people? Just so you know what can go wrong with lungs, that is a photograph of a human hair. So that's the human hair, the big wide thing. Those white particles that look like little slices of rock, well, they are actually little slices of rock. That's respirable crystalline silica. That is the stuff that actually, in the clouds of dust, when you walk past the guys digging up the roads, you can't see it. It's so small, and the size of it means it can get all the way down into those little places where that 1 micron thick membrane is. Imagine a 1 micron thick membrane being faced by a razor blade. That's what happens. Your basically lungs get sliced from the inside by thousands, millions of these little particles if you're breathing in silica. I love to do the good news first. It's great. I'm a bit of an engineering geek. I used to work in aerospace years ago, so I still love anything sort of technical and that. I love watching documentaries. I don't know if you saw the one on Tideway about the railway under London. There's the one on, Tideway. Tideway's the sewer. I'm getting mixed up with Crossrail. The £1 billion sewer. I don't know what you think of when you think of something like Tideway, this project. For me, it's probably one of those, a tunnel boring machine. Awesome little factory that goes under the ground, digging out tunnels to create this amazing infrastructure of concrete pipes under the city. Yeah, I can get really into that. But actually, if you talk to my colleagues at Tideway, they'll say it's not just about that. It's about these folks. It's about the people that do the engineering. It's about the people that do the work. So I guess what do you see here? What would you label these people as? Are they operatives? Are they workers? Are they a human resource? Are they a human capital? Who knows? Can we put them in a spreadsheet and count them? Give them a value? These are all individual people just like you are. All those thoughts that Liz Sneddon was talking about going around in her mind, each of them has that. These are people. If we want to have a health and well-being strategy and approach this stuff strategically, we need to start from a people-focused approach. Now, this is courtesy of my colleague Jenny, who's in the debate, Jenny Armstrong next, from Tideway. But Tideway look at 5 components of a health and well-being strategy. Starting over there, you've got health promotion. Probably what we think of when we think of well-being, the added value activities, whether that's about diet, exercise, mindfulness, mental health, those sorts of things. Then personal support. We talked about employee assistance programs earlier, but you've got mental health first aid, training, upskilling our managers who might be great technical experts, but they've got to handle these complicated things called people. But then moving further over to the left-hand side, organisational arrangements. Now, there we're talking about vision, values, policy, respect and inclusion, flexible working that Carey was talking about earlier. Actually, I was talking to somebody at the lunch break, and the guy was saying that it's almost like it's easy to have those things in place and be told to do them, but it actually has to be felt on the ground by people. A nice term, felt leadership. People actually have to see that those policies mean something in reality because somebody cares. But then also, basic needs. These are the more organisational, structural things. You know, it's easy to provide free fruit, but what about contracts, pay, working hours, family time, welfare facilities, job security? If you're looking at some of the stresses in mental health, it's probably more at that end. And then finally, prevention. Preventing people being exposed to health hazards This is the unsexy stuff. This is the noise, the dust, the fumes, the vibration, the stress, the musculoskeletal exposures. Now you notice that I've put the arrow running from left to right. I've done that because from my time at BOHS, by the way, I'm not a health and safety professional, so I'm not coming here trying to teach you guys to suck grandmother's eggs, but what I found when I was talking to businesses was very often when it came to health and well-being, they'd start over there on the left. Why is that? Well, because it's easy. This is the easy stuff. This is stuff where we put the responsibility on the individual to make better choices. Well, I'm not saying that's a bad thing, and we know the benefits for productivity of good well-being programs. There's plenty of research. Carol Black will tell you all about that. And then as we move over this side, it starts to get harder once you start to come into organisation arrangements, some of these basic needs where you're talking about contracts and the way things work in an organisation. And then maybe, lastly, we finally think about prevention. Actually, what I would say is the arrow should be the other way round. Because isn't our first thing that we should do no harm, as it says in the Hippocratic Oath? I mean, what's the point in all the other good stuff if the very work we give our people puts them in harm's way in the first place? I thought we did believe that prevention was better than cure. We certainly believe it in safety. I'll come on to that in a moment. And rather cynically, I would say you can't yoga your way out of silicosis, you can't be counselled out of asthma, and you can't eat fruit to stop occupational cancer. Now, professionals working in wellbeing often say to me that health and safety has had it easier because you've got the backing of the law in terms of the Health and Safety at Work Act. Well, my view is that that's probably been true for accident prevention, but I think despite the law, it hasn't been true for ill health prevention. That question in the debate in the session earlier about do we need more health and safety regulation? I used to ask my members at BOHS that all the time. Do we need any more regulation? And you'd think occupational hygienists whose job it is to protect people from exposure would say, yes, we need more regulation. Generally, they said no. We just need to do what's already there. We've actually got the laws. We've got the occupational exposure limits. It's just hear no evil, see no evil. There is no evil. Now, if you look at safety, the truth is the UK's done a great job. We are actually respected around the world. 100 years ago, the graph that David referred to earlier, we were killing 5,000 people every year from accidents, walking over the bodies of the workers at the factory gate, as another chief exec once said to me. Over the last 100 years, that's come down fantastically. You know, it hovers around 150 now. Actually, as an ex-physicist, I can see the diminishing returns in that. It's almost flat now. We can debate why that is, but there are diminishing returns. Now, 150 is still too much, and I wouldn't say safety's sorted. However, in the UK today, total work-related deaths are standing at around 13,000 per annum. So just to put that in context, that's 1% accident deaths and 99% ill health and disease deaths. That feeling of tightness that you all felt, you know, in that third breath. As I say, that's how 12,000 workers die every year. And these are all the stats are taken from HSE Statistics website. I haven't made any of this stuff up. It's all approved by the Office for National Statistics. So everything I quote comes directly from there. It's been on there for years. I don't know why, but we just don't seem to be aware of it. Actually, when you talk to the HSE experts, they'll tell you there are a lot more deaths than those disease deaths where there are other confounding factors like smoking or diabetes. But the HSE isn't allowed to report those where workplace has been a part of it. They're only allowed to report the stuff they can be sure of statistically and epidemiologically. So, but first thing you'd probably say to me, isn't this all just granddad's disease? It's all caused by long past exposures. It's all to do with asbestos, isn't it? I wish it was. About a third of it is asbestos. 2/3 are caused by other cancers and lung disease. And not wishing to be too controversial, but I'm afraid these deaths far outweigh accident and suicide deaths at work. And in no way am I de-emphasising the importance of dealing with those things. Okay, I've got the job of chairing the debate next, so unfortunately you guys know where I stand on that question. I'm going to have to be impartial next door. That'll be hard. But if we are going to look strategically, then I'm trying to help you to see the big picture of health and well-being. So rather than just talking about mortality and death, let's talk about morbidity, so illness that doesn't lead to deaths. In the HSE stats, you'll find, if this was all granddad's disease, you wouldn't get this. For potentially fatal occupational illnesses each year, there are 13,500 new cases of occupational cancer. So if this was all granddad's disease, how come that's happening every year? How come David's clinics keep being full decade after decade after decade? 20,000 new cases of respiratory disease. If you look at diseases that people get at work that are just debilitating and aren't potentially fatal, there are over 1,000 new and existing cases of HAVs, hand-arm vibration disorders, 7,000 new cases of occupational skin disease, 23,000 new and existing cases of noise-induced hearing loss, and the numbers just keep going up. If you go to musculoskeletal, something like 156,000 new cases, and stress, huge numbers, 239,000 new cases. Overall, the UK loses 31 million working days each year. Of that, 27 million are due to work-related ill health, so 90% due to health. Sometimes I like to go to conferences and say, how much of the health and safety industry, at time, effort, resources, conferences, training, management systems is spent on safety and how much on health? It's probably the reverse of all those deaths. Annual cost of the economy, HSE estimates at 15 billion a year, of which 10 billion is due to ill health, and they haven't even put in the costs of all the long latency existing disease into that. That'll come later. And of course, there's the human cost, you know. We go back to those Tideway people. They're people. I just want to try and play you this video. I hope it works. It's buried behind that photo. This is a Crossrail video that they produced with actors, so it might be slightly cheesy in places, but it was to try and bring that sort of future effect of the health risk, the future disease effect into the present, because that's the problem. Latency is a big problem with all the health stuff. Let's see if this works. Be patient.
Camera set.
Just enjoy yourself. Be yourself, yeah? Look at me, not at the camera.
Oh, yeah, okay.
So, Jenny, would you consider it important to wear a dust mask in the working environment?
Oh, I thought you were going to ask me about health and safety. No, they're a good idea. They can be a bit fiddly to put on sometimes, and if you want to talk to someone, you might forget to put it back on afterwards. No, they're helpful, I'm sure.
Do you wear a mask in dusty working environments?
Yeah, a lot of the time. Well, sometimes. I actually find them quite uncomfortable.
And have you noticed any impact on your health over the last 5 years?
No, not really. I mean, some of the other lads, they cough a lot, but, you know, they're probably on like 40 fags a day or something.
Outside of work, would you say you lead a healthy lifestyle?
Yeah, I guess so. I eat pretty healthily and I like having my friends around the house, but...
Where do you see yourself in 10 to 15 years' time?
See where that tightness of breath comes from in the third breath. I know that sound all too well. Now, we say health and safety is a priority, but for so long what we've meant is safety is a priority. Now, I'm not blaming anybody, but why is that? I actually do get it. I've been privileged in my career to go and visit lots of different sort of sites. So I walked down the Crossrail tunnels at Farringdon when the construction phase was in progress. I walked the Toyota production line at Burniston in Derbyshire, right from where the metals come into the cars drive out. And I've climbed all over a major BP chemical works, Coma site on the Humber estuary, By the way, I was escorted on all occasions, I can assure you. At every turn, there were obvious safety hazards, things that could maim or kill me. Huge moving machinery, steep stairs and heights, robots, forklifts, swinging barriers, pipes with acid in, filled with nasty things. The safety risks were literally in my face. And that's one of the things. Safety risks are so much more obvious and visible to the ordinary person than health hazards. Serious safety risk is an ever-present factor, and if something does go wrong, then accidents have immediate consequences. The thing with the disease stuff is people don't die on our books. They die at home, they die in hospital, out of the way. But with accidents, it's immediate, it's there and then. And if something goes wrong, we worry about HSE notices, investigations, negligence, reputation, corporate manslaughter. The financial, legal and human stakes are all pretty high with safety. So why is health the Cinderella? Well, we've just said the obvious thing. Safety hazards are easier to spot than the ordinary person. But safety risks are also easier to control in many ways. The probabilistic nature of safety risk means some controls, like you put a machine guard in place, I can't actually physically put my arm in. It doesn't happen. But with health, it's deterministic. So that means exposure has to be quantified and then reduced. It means that risk can rarely be eliminated, but just brought down to a safer level. Safety has acute consequences. You know, if you fall off a ladder because you've not been working correctly and safely, there's a body on the ground. The head is smashed, you know the name of the person, they go into that 150. With health, like we say, the numbers are huge, but they're dying out of sight and out of mind. But they're dying because of things we gave them. Finally, many safety risks can be controlled using the same or similar measures, whereas with health, one size doesn't fit all. Now, I've probably done enough bad news. There is actually some good news. Certainly in the 10 years I've been working in this sector, I've seen health and well-being come up the agenda of both business and the regulator. And just to point out, I can see some of my HSE colleagues at the back, some of the things that great things HSE's been doing on health over the last few years. In 2016, they published Help GB Work Well, which was the national strategy, and tackling the costs of work-related ill health was one of the top priorities. The minister's probably changed about 5 times since then, but I remember at the launch, the minister talking about occupational, well, actually industrial hygiene, he used the American term, but I nearly fainted. They understand what's needed to deal with this. In 2017, HSE launched Go Home Healthy. It's campaign focusing on lung disease, MSDs and stress, and that's still ongoing today. In 2018, there was a programme of inspections beginning with construction where health exposures were prioritised. We were talking about training of inspectors earlier, and I know that the health and safety inspectors have been given specific health training, and that programme is ongoing. And to be fair to them, a lot of them come from a safety background and don't feel they have the confidence without the training to challenge and address the health issues. And as you'll see, that's because you need a more scientific perspective when you come to the health side of things. And that training continues as a priority. So obviously, I'm trying to twist your arm morally, but there are very good business reasons why we should address health. Firstly, we've got an ageing workforce demographic. So we need workers to remain in work longer, and inevitably that means people managing multiple chronic health conditions as they get into their 50s, 60s and later. You can help keep them fit for work by protecting them from exposure risks that would otherwise exacerbate the challenges of those later years. Only trouble is it needs a longer term perspective, not just a short term perspective. And secondly, at the other end of the workforce, you can demonstrate to health-conscious, tech-savvy young millennials with their iPhone watches with their noise app on it now, and I hope and expect to see more of that sort of thing coming in the future, you can demonstrate to them that you're genuinely concerned about health and well-being, that yours is an organisation that cares about health and will protect it, not just measure it as it is today. Thirdly, you can ensure the benefits of your well-being programmes are not undermined by a failure to control workplace exposures that could nullify the good of those programmes. Like I said, you can't eat apples and get out of cancer. Fourthly, we've said HSE is focusing on health inspections. We do quite a bit of work in the construction industry, and that's where that started. In fact, I was in a meeting with a large group of companies, and I'd been telling them this in some awareness briefings for them. Went back 3 months later, and first thing one of them said was, we've had one of those inspections on health. They didn't believe me the first time. Second time they did. Fifthly, sometimes you get an opportunity for direct cost saving. If you're outsourcing all of your exposure risk assessments, you could just be spending money unnecessarily because it's not part of a strategic programme. And finally, you can demonstrate a genuine commitment to zero harm. I mean, without a health protection strategy, you've seen the stats, zero harm is just a load of empty words. It's just corporate speak. So, I want to give you a really simple diagram. I used to do quantum mechanics as a physicist, but now I only do pie charts and little 2x2 matrices. So there are three, this is really simplified, but three broad aspects to health in the workplace. First one, occuhealth. Okay, if I say occuhealth, what do you think of? Nurse, doctor, somebody in a white coat, go and sit down, take your blood pressure, that sort of thing. That's the classical understanding of health at work. And it's the domain of doctors and nurses, things like fitness for work, health surveillance, rehabilitation, all great stuff. What it's focused on is managing the health of the person as it presents today. Okay, second one, sort of new kid on the block, workplace well-being. It's all about encouraging healthy lifestyle choices. And obviously there's benefits for individuals and employers. We know the stats about productivity improvements. But what this does, it's about individuals making better choices. So the onus is on the individual. Neither of these two protect people at work from the risks the workplace itself creates. That is the domain of occupational hygiene. That's all about protecting people from workplace health risks. It's not about clinical treatment, and it's not about health promotion. It's about protection. So occupational hygiene is a cross-cutting scientific discipline, covers elements of physics, chemistry, biology, engineering, medicine, psychology and management. It takes 7 years to become a chartered occupational hygienist after your first degree. Now in the past, I think organisations fell into the trap of medicalising workplace health. We made it about how your health presents today and how we can help you cope with that. I'm concerned that as we go forward, we'll make it all about well-being because it's the easy thing to do. And we'll miss the employer's legal duty in the Health and Safety at Work Act to control exposures, which gives people disease and those statistics that you saw. So, you know, we've focused on safety for many years, and I get why, because it's the immediate thing. It's nice to hear other people say that health and well-being is on the rise now, but I would hate that we say we're doing health and well-being and really we're just doing well-being. Because if we do that, none of those stats are going to change. Just conscious of time, but just to briefly say, health is a multidisciplinary thing, okay? So we want people to be supported in work, that's the occupational health management of health. We want people to be fit for work, that's the well-being side, but we want people to be protected at work as well. It's ironic, really. I remember when I first came to BOHS, I read some of Robin's stuff, the committee report before the 1972 Health and Safety at Work Act, and he actually split health then, workplace health, into two branches. So he talked about medicine, occupational medicine, the domain of doctors and nurses, but then he talked about occupational hygiene, the province of scientists and engineers. We've added in well-being. Somewhere along the way, we seem to have forgot hygiene. Now, you're probably thinking you've not mentioned mental health. Okay, well, let's come to mental health then. These three circles apply in mental health. I won't quote you the statistics. Mental health is a huge issue. But when someone experiences mental ill health, there is a clinical dimension. Okay, you might need initial chatting to a friend, but if you've got mental health issues, you need some clinical support. In an ideal world, that occupational support would be linked with the primary care system. We've got a way to go with that. But there's also a place for well-being in terms of reducing stigma, promoting initiatives that produce better mental health resilience. But if workplace issues are involved in creating the stress in the first place, no amount of chatting to your friend or mindfulness or antidepressants will cure the issue. I speak from personal experience, I know. We actually need to take a long, hard look at the organisation itself and move on to some of those things in the HSE stress management standards. But the trouble is that's hard, because that might mean organisational changes, culture changes, contractual changes. So I love it that we're talking about it, but I must admit, part of me looks at it and goes, when are we going to do this real stuff? When are we going to get to the real stuff? So these 3 circles apply in mental as well as physical. Now, leading on health and well-being can feel a bit head-scratching if you've worked all your life in safety, because you've got the scientific element to it, the multidisciplinary element to it. It's long latency. I've got to get my head around the fact that I'm dealing with the exposures, not just how people are presenting with their health at the moment. But admitting that we've found it hard is the first stage to find a solution. I remember a few years back speaking at Excel. It was a health and construction leadership event. So construction senior managers and directors, probably about 300 in this long room. And I was doing my usual bit with my 3 circles. And then we went into small groups. I thought, well, I'll shut up now because I love talking. I'll try and melt into the background a little bit. And there was a bit of a debate going on. And I could see one guy, some check director from some big civils organisation, who I hope isn't here today. And he was looking at me. He kept looking up at me, and his face was going red. And his body language, he was tensing up, like he was going to punch somebody. And he kept looking at me, and eventually the chatting sort of died down, and he sort of looked at me and he went, Steve, are you saying that after all the decades of work for safety, on systems and management and procedures and training and culture and qualifications and competency and all of that, I've now got to do the same on health? And I sort of let him vent, and I looked at him and I said, yeah, what else were you thinking of doing? I mean, respect to him, because then he put his head in his hands. I could hear that penny drop. He realised, oh man, there's a job to do. And we do it in a risk-based way. We don't just do isolated initiatives. We actually risk assess properly on health, and we do it in a step-by-step methodical way, and we get the right competencies. Health and safety professionals are my heroes. I've worked with many over the years, and the ones I really respect are the ones who will stand up and say, and I remember Danny Martland, BA Systems Director for Health and Safety. He came to BOHS annual conference one day, and he stood up and he said, I'm Danny Martland, I pride myself on my qualifications in health and safety. He said, but I've got to admit, I'm a safety director, and I've got to learn about health. And then he started to talk about what BAE were doing. How are we doing? He's the sort of guy I've got respect for. And it takes leadership from people like that to acknowledge that this hasn't been done properly and we need to do it properly. And actually it's a culture thing, like safety. You probably recognise this sort of ladder. This is Nick from Patrick Hudson and his safety culture ladder, where he's got different levels that an organisation is at, right down from pathological at the bottom to generative or excellence at the top. And as you go up that ladder, as you transform an organisation, by the way, that's really, really hard, as I'm sure those of you working it know, the organisation becomes increasingly informed, and there's increasing levels of trust and accountability. And I sort of tongue-in-cheek add health to this. So pathological level, well, when it comes to health, we won't get caught because the health risks can't be seen. Oh, maybe we're getting a bit better, reactive. We act when we see ill health in somebody. Remember the latency thing? It's way too late. We should have done it way before then. Calculative. Well, we've got systems to assess risk, and we actually put health controls in place. LEV, substitution, whatever it is. Proactive. We go out looking for health risks, and then we do this scary thing called verifying that those controls we put in place actually work. 5 years later, is that system still working? And then right at the top, we design out health risks at source. I've just managed to get in with the Highways England Principal Designer Working Group. We do a bit of work in the highways industry, and trying to get to designers to think about designing processes in construction so that they don't need to do all that cutting, grinding, chopping, sawing, dust creation. Yeah, well, that's a challenging task. But actually what I've found is you need another level at the bottom. It's called oblivious. That's where you find some organisations that say, what's work got to do with health? I wish I didn't have to have that. Yeah, I won't dwell too much on this, but even organisations that work in the middle of that culture ladder tend to rely on PPE. I was reviewing a huge database recently of issues, incidents and near misses that's supposed to be health and safety. I went back 5 or 6 months, hundreds and hundreds of issues that had been raised by different companies working, and I found about 5% that were to do with health, and all bar one of those were they weren't wearing their masks and they weren't wearing their gloves. Nothing about dusty sources, noise sources, investigating any of that, just the PPE side of it. So what does good look like? Well, as I wind up now, this is what we at Steve Perkins Associates would say we want. This is our model. Everyone protected at work at the centre. To achieve that, we need 5 critical success factors of health protection. And a bit like buying houses, it's location, location, location. With this stuff, it's awareness, awareness, awareness. So we start with hazard awareness. Try and move that into, health ownership. They tend to go in a flow. We need to connect the people at the top and the values they espouse with the behaviours at the bottom. There tends to be this huge gap that we say the right things and do something different. But that's what we look for. Proper risk management. We've got loads of great learning on safety as to how to do a risk management approach. We do the same with health. That's how it needs to be. That needs to lead into culture change. We talked about culture already, so it has to be embedded. And finally, protection assurance. There has to be a way of verifying those controls and checking that they're still working and we're not exposing people to things we shouldn't. And then, very quickly, some strategic enablers that need to be in place. And you'll notice that these are probably very similar for any major change in an organisational culture. Stakeholder engagement, leadership coaching, particularly important with health because people are scared of it. They feel the terminology is a bit unusual, they don't get it, so coaching them through that is important. The right competencies, leading indicators and effective systems. I mentioned we're working in the highways industry with the M25 network at the moment. All credit to them. They've recognised that they've been doing safety well for years. They're doing well-being now, but they're realising we've missed exposures. And if you want to talk about tarmac laying and planing off tarmac on motorways, I can tell you there's a toxic mix of exposures in there. But they recognise it and they want to do something about it. Finally, quick quote from Napoleon. He said, "A leader is a dealer in hope." Now, personally, I think optimism is one of the things you can't delegate as a leader. We've got to be optimists about the fact that we can deal with this. Rather than see it as too hard, too difficult, we can deal with it. And the story that I take most encouragement from is the smoking issue, public health issue. You know, if I wind back to when I was a 20-year-old, which is a long time ago now in a galaxy far, far away, you go to a sixth form party or something at uni and pubs would be full of smoke. Not just pubs, planes, trains, cars, hospitals would be full of smoke. Doctors smoked. Yeah. Imagine that. And imagine the power of the tobacco lobby behind all of that to keep that going. Some of the richest companies in the world. Don't worry, we're on track. If I say to my kids who are grown up now, and I've got grandkids as well now, and I said to them, "Hey guys, you know you're going out this evening. You realise that restaurant you're going to will be a smoke-free environment?" They're like, "Dad, what do you mean?" "Dad, that is the water this fish swims in now. You know, it's accepted." A bit like the seatbelt example that somebody gave earlier. So don't tell me it can't be done, because it can. If we can change that, the workplace is a smaller subset of the whole world. We can do it. So I wonder how you react when I tell you all this. Are you sceptical? I don't see the exposures. It's not 13,000. Show me the bodies. Are you like that Czech director feeling overwhelmed as he put his head in his hands? Maybe privately, of course, you're more calculating. Well, they're not going to die on our books, we'll just do the cheap stuff. Or are you ready to investigate it further? You know there's a problem and you want to do something about it.